Hi, good afternoon. It is February 17th, and this is House Healthcare. We're starting our afternoon off with Commissioner Hawes from DMH and Jeremy, we all just got to meet. Welcome, and wanted to provide some follow-up and additional testimony on some things that we've heard. So go ahead.
Thank you. Good afternoon. For the record, Emily Hawes, Commissioner for the Department of Mental Health. And here with me today is.
Hi, I'm Jeremy Terry, and I'm the Crisis Director with the Department of Mental Health.
So we're going to be offering some follow-up testimony related to information about how the Department of Mental Health views training for law enforcement and first responders as it relates to our proposed reduction of the Team 2. So I'm going to transition it over to Jeremy and we'll go from there. Thank you.
So thank you, committee, for letting me come here today. I have like a little spiel, if you will, but please, by all means, just interrupt me and ask me any questions that you want. But my team at the department is new. It's just me and two other people, brand new to DMH, that oversee all the crisis services, including the 988 Lifeline, Mobile Crisis, the urgent cares, and a huge part of what my team does is also training. So Team 2 was fantastic, made great relationships with first responders, police officers, and the crisis services. But all of these crisis services that were initiatives for the department are new for the state. And so because of that, the training needs also evolved. And that's where my team really came in to help educate the police, EMS, fire, all the first responders that we could get to about 988, about the new enhanced mobile crisis, where the mental health urgent cares are located. And so a lot of our trainings, we have one specific training specialist who is in contact with the chief of police. We've contacted literally every chief of police who's interested in talking with us and having the training. And they're really scenario-based trainings. A lot of it is based on, here's the crisis services. This is what's available to you as a provider in the state. And now go ahead and ask questions. Let's use the room. We'll bring the designated agency with us. We'll bring a 988 call taker with us to be like, this is what they would do. This is what mobile crisis would do, depending on any situation. And they're all different depending on which community you go to. And that's really the crux of what our crisis trainings look like.
Jeremy, do you mind if I add on a couple of things? We testified a little bit about this during our BAA testimony, but the Department of Mental Health worked very closely with our 911 operators to develop a policy that supports individuals who receive calls through 911 and that someone on the other end might be experiencing a mental health or substance use crisis. And so Jeremy and his team also helped develop the protocol that our 911 operators are utilizing to transition appropriate crisis calls over to the 988 line. And so what you're hearing here is that the Department of Mental Health has prioritized supporting our community as best we can, making sure that we have someone to call, someone to respond, and somewhere to go, and being able to manage the training components that go across all of those different entities is one of the reasons why we'd like to bring that in-house. I know that some of the testimony highlighted a concern that it would be presentation style, and that's not our intent. We would be a mixture of, very factual information, plus, as Jeremy said, scenario-based, decision-making, and also de-escalation. And like one of the questions I think we've gotten is transitioning the Team 2 program to DMH. And I'd like to shift that a little bit. There are really great components of Team 2, but we wouldn't just be taking Team 2 into DMH and start delivering Team 2. There would be a shift in the information, the scenarios, and how that training looks. We wouldn't just be redoing the Team Two training under the guise of the Department of Mental Health.
Brian,
I have three questions. One, does DMH design the current online trainings that all the mobile crisis teams are doing that are through Relias, I think?
We don't design those, no.
Are you responsible for them?
Well, Reliance makes the trainings and then HCRS, who we contract with us, we pick which ones we think are most appropriate.
Are you planning to offer those trainings to the other providers besides crisis workers as part of your shift in training?
Yeah, we could consider that. Yeah. Are you saying, I mean, because our goal would be that anyone working within the crisis system, whether they're somebody from, say, First Call or someone who's mobile crisis response or something else, for some first responder, that folks have a shared language across whatever lens they're approaching a situation.
That's what I'm getting at. Like, for example, I'll just randomly pick one, like working with military families and military culture is one of the trainings we take. If the police were taking that and the firefighters and the EMTs, as well as the mental health workers, that would probably improve the functioning of this system. The second question is there still going to be in-person cross-training between provider types?
Yes.
Okay. I don't think you need to say more about that. The third question is, has the department reviewed the recommendations of the Health Equity Advisory Commission regarding training of healthcare workers and more?
I'm just sorting through my brain because I have a couple of health equity committees that circulate in my world. We can if we haven't. Most of our trainings are informed directly through the health equity committees.
I'll highlight one recommendation, but I'd be happy to just make it easier and send you the link to the report so you're not trying to find what I'm talking about. But it was a few years ago and it did come to this committee. I know some of us were on it then, not everyone. I think probably 1, 2, 3, 4, at least 4 of us were, if not more, where that report came out. But it had an interesting recommendation, which was that in order to promote equity, that training, there should be cross training and a unified system, like a sort of a broader language of training across all actors of government, even legislators, ironically. So it was saying even legislators should have to take the same employee training as police. Because in terms of health equity, because if there's a disconnection from the front line and the people at the top. So I just share that because there was some important pieces of it that if you are, whether you or Team Two moves forward with this, I feel like we haven't really followed through on those recommendations and it might be worth looking at.
Yeah, that's great. One thing that, I mentioned was how valuable language is when working across systems. And having a shared language would help with that access to equitable response.
Pivoting to a different topic, I didn't see anything for the PRTF in your budget. Can you speak to where that's being funded?
Yes, the PRTF comes under the DEVA budget. So they are overseeing the billing components of that, just like they oversee the billing components of the Brattleboro retreat. But I can tell you that we're in contract negotiations right now with the retreat, and that is with glass half full on track for a July 1st of 26.
Okay. The other issue that I'm kind of grappling with is I looked at the dashboards that are on your website, which are amazing, by the way, and specifically looked at the caseloads that our designated agencies are carrying right now. And for folks who haven't looked at it, there's sort of a minimum threshold for payment. And then once they reach that, the designated agency gets the per member per month, right? For that person.
Yeah.
They get a fixed rate for that person. The way that fixed rate's determined, correct me if I'm wrong, is that says it all. So you have in this budget about 5 million
Mhm.
for the anticipated additional 5 CCBHCs.
Mhm.
My understanding is that some of the services you're recommending in your budget be rolled into the CCBHCs were not incorporated in those 5 folks' cost reports.
I would need more specifics, but what I have heard is that a question has come to me about elder care, reach up and YIT services and whether or not those should be rolled into the CCBHC rate. And those specific population-based services are not CCBHC eligible. And what we did show was, for instance, there's around just shy of 300 folks who receive YIT services. 90% of them have Medicaid or insurance, and they can still get services. It's not under the umbrella of a population-specific service.
Yes.
Yep, youth and transition.
Thank you.
So everyone understands what that is.
Yeah.
Is there a way for all of the recommendations in the budget that we were suggested will be looked at as part of the CCBHC case rate?
Mhm.
Is there a way to transition that so that those services are not going to be unfunded mandates to our designated agencies?
Yes, so we have a CCBHC manual linked on our website that provides all of the qualifying services that an agency should be billing for a CCBHC service to get the daily rate. We did a TPS 1, which is a daily rate for a qualifying kit. And it is our impression that even with those targets in the current case rate, and you look at the amount of people that folks are serving in those 3 buckets, elder care, reach up, or YIT, there's not such an off balance. There's not so many people being served from elder care, youth and transition, or reach up that would offset, it would help folks meet their targets if they're not meeting them, likely not go over.
Okay,
So they are funded for this.
just to be clear, my concern is that when I looked at those caseloads, a lot of folks are at or going over recently within the last year. So that's my concern. I know 2024 was a little bit different in the trends, but
Mhm.
my concern is that if we remove the funds for those, we're going to have huge requests in the BAA to cover the losses.
Potentially. From the cost report work and the 2 agencies that are currently delivering CCBHC care, we've based that CCBHC new initiative dollars. So I think there's like 5.4 million in our CCBHC initiative. That number is a number that we got from understanding what their current billing is and being able to anticipate what increasing access to services look like. And with elder care, it won't be that you're providing elder care service specific for that individual. That individual could receive services under the CCBHC. We also know that most of those services weren't done at home. They were done via telehealth or out in the community somewhere else. Those can also be managed through a traditional CCBHC. Or if somebody's not going to be a CCBHC, they would fall under their case rate. And our goal is for the agency to bill for those services.
And also to be following best practices. And I don't
Absolutely.
think that's a best practice to do telehealth for that population.
Not
Correct
always,
me if I'm wrong.
not always, but some would prefer it.
Lastly, did you factor in that 5 million? Does it include the 2% up for Rutland and Fairmartin?
Oh, for the rebates, is that what
Different
you're?
rate,
Yeah,
yeah.
you get rebates after year 1, and so we're not there yet. We'll be there at the end of June.
Brian, did you?
Well, I have a question about another DMH topic while we have you here, because it sounds like you kind of opened up with Team 2, but we're talking about other appropriations now.
Actually, I have a question about that too, but go ahead.
About Team 2 or another stuff?
Well, the other stuff.
Well, I'll ask this if it's okay.
Yeah, sure.
It's related to mobile crisis though,
Okay.
so that's why with Jeremy here, I was like, this might be a good question. So it's the BHL, the app that like some workers at least are like concerned about that. I'm curious, like, if you could say more about how much it costs per year per worker to pay for that service.
I would have to get back to you on that. I don't know exactly how much it is.
Do you know how much it is total?
It's like 350,000 a year for the entire subscription costs, something like that. And it goes up a certain amount each year, but year one, it was about that.
Yeah, the reason I asked about per worker is because I thought it was like 7 something a year. So this number is going to be wrong, but I was trying to do the math with other crisis workers and it was like paying 1,200 a year per worker. So if the system's spending 100 a month. No, it's going to be less if it's 300 something.
Yeah.
It could be like 50 a month per worker.
Yeah.
That we're spending to have the system, but I'm wondering, what are we actually gaining for that expense? And that's really the appropriations question here. Because it sounds like it's complicating things on the ground. I'm not a witness though, so I can't really go into that. We can always hear from workers or whatever if we want, but I'm curious from DMH's perspective, what do you see as the gain for that cost, that expense? Like how is it going to improve our crisis response system?
So how is BHL going to improve the crisis?
Yeah, that specific investment.
Yeah,
VHL is.
Behavioral Health Link. It's the name of the technology that we work with. So it allows for the crisis continuum to be married essentially. Without some sort of communication or technology platform, mobile crisis, the other crisis centers, the other DAs, and 988 would have no way to communicate with one another. And so when we were starting mobile crisis, we had health management associates do a needs assessment for us. We have been trying to follow SAMHSA best practice guidelines. Everywhere says you should really have a GPS-enabled dispatch technology. And that was a recommendation for Vermont when we started mobile crisis too. And we agree that if someone calls 988, they should have access to mobile crisis if they need that. If someone calls NCSS crisis, but they live in Burlington, they shouldn't have to be transferred. You know, it just gives a better seamless connection statewide for all of the crisis services.
One thing to keep in mind with enhanced mobile crisis is that it is not defined by a designated agency or county. So agencies can cross-respond to individuals if they're the closest team. So if somebody's in, say, the Virgins area and there's a Howard Center or NCSS team closer than the CSAC team, you can respond to individuals who need the service. And from a organization and efficiency lens of delivering care to folks in the quickest way possible, knowing folks helps to call folks out to the closest team.
One of the challenges of that I want to express, because maybe then you could weigh in on what the solution is that the current workflow for crisis, I don't know, so this speaks to your point, I don't know the workflow in Washington County, even though we call them if we have to coordinate with them. Like, it's not like we don't talk.
Yeah.
Just we will use the phone like the old fashioned way, and like you like fax them or fax email them things, like that we do communicate, but it sounds like you're moving towards a more centralized system. One of the challenges of the workflow is that the current crisis teams in Chittenden County have to return to the office or to another location. Like, we can do it at the police station or at the emergency room at our home if authorized. We have to do paperwork before we move on to the next person. We don't just like stack up assessments and then stay until all the paperwork's done. So if a team had just seen someone in the south of Charlotte, they would still have to do their paperwork before responding to someone in Ferrisburg. I think that's a really good example, like how close it could be. So I think that I'm wondering like how BHL is going to help with that barrier. And then the other thing about.
Can I ask my question? Because I have to go.
Okay.
You would stay off. DHL would stay off, so you would say that you're not available even traveling back to the office. So someone's not going to dispatch you in the south of Charlotte if you have to go back and do a note.
But then what's the point of having BHL, I guess, because you still have I want you to ask your question and then we can come back to this. The chair needs.
Just because it had to do with budget, I'm just thinking about one of the other budget asks that we had was around 211. And I know that you're incorporating 988 and 911, so that there's more of a seamless, closed loop, I guess you would say, with that, along with mobile crisis. And I'm just wondering if I'm imagining that there are people calling all sorts of numbers for all sorts of things. And I'm wondering if there's like a coordination with 211 with 988.
Yeah, that's
as
a great
well.
question. Yeah.
There's not currently, is what I'm hearing.
I do think 211 has protocols, but I don't,
Yeah.
yeah, do you want to speak to that?
So 988 used to use the 211 system, and then Vibrant Emotional Health, the national vendor, moved us over to the unified platform. And I think just during that transition, though, 988 had to work with 211. And so there was a really good time for them to communicate. And so there's no like seamless transition the way maybe 911 has with 988 and vice versa. But I think the 211 folks, I don't want to speak for them, certainly know when to transfer the call. And I know that 988 understands the 211 services and when to tell people to call 211.
And the other thing, just really quickly, we also have Pathways has their warm line.
Yes, they do.
Is there still a need for that? I mean, I believe that's been around it was around before 988.
Yes, so the Pathways warm line is run by persons with lived experience. And there are individuals who would prefer to utilize that resource versus a 988. And so we want to have as many resources available as possible. So that line is still up and running.
That was it, Brian, if you wanted to continue first.
Thanks. I wanted to make sure.
Yeah, we do need to kind of move on, but.
We can talk more. That's operational stuff that the committee doesn't decide anyway. I'm just trying to understand how it's going to improve the functioning if we approve the expense. So that's my kind of intent in this role. So I'm trying to delineate from being a crisis worker. My last question related to BHL is you mentioned the intent seems to be to unify the system more across agencies. Is there going to be a unified medical record system coming at some point, or is there going to be a way to create interoperability around that? Because that's going to continue to be an issue.
That's my dream. Right now, I can say we're working with HCRS I can only speak for the crisis system, with NetSmart and Credible to allow for
Which are electronic health record platforms.
Thank you.
the API integration, no idea what API stands for, some IT term to make BHL be able to talk with the EHR and vice versa. So the clinician can choose where they want to do the note.
Thank you.
And
see the other number.
healthcare
Yeah.
systems in general are trying to solve the access to record challenges. And with 42 CFR Part 2, which is HIPAA, protected health information, which just got changed starting yesterday for increased access to folks with substance use. But there have been challenges for centralized electronic health record management. That's all of healthcare challenge. I don't think that's just a mobile crisis or mental health system challenge.
Topper.
Quick question. Vital, what role are they going to play?
I think Vital, if folks don't know, that is the work the state invested in for a centralized electronic health record, essentially for folks to submit the record and be able to get it out. In some ways, that's working really well. This is an area, I think there's some opportunity for improvement there.
Thank you. Thank you, Commissioner.
Thank you.
Jeremy, nice to meet you.
Yeah.
So I'm going to turn this over to Daisy to chair, and Daisy and Lori, both of you, thank you so much for all the work that you've done on the budget. They're going to be presenting a spreadsheet that has essentially everything that we've been hearing over the last couple of weeks around budget. It is my hope that we will go through the items, make sure that everybody understands what they are. Ask any questions that you have about the individual items. If you need clarification, we're on very short time. However, try to get you some answers. I think I'm going to leave with one thing. I'm going to come back here in about half an hour or so. Remember, we are a policy committee and we are being asked to make recommendations to the appropriations committee on where our priorities are. And where our priorities within policy are. We're not a money committee. So, it's not up to us to figure out how to fund anything. It's up to us to make recommendations and then we let appropriations either take our recommendations and toss them in the trash or do whatever they want. with it. Okay, and find money. So, thank you. Thanks, Steve.
Thank you.
Be back soon.
Okay. Does everyone need a minute to orient themselves to the spreadsheet? I know a couple folks haven't done this process before. Karen?
Yeah.
Val? Okay. So on the left, the section number refers to the section of the governor's recommended budget that item was recommended in. So what we've done is we've taken things that need us to make a decision on and pulled those in here so we can weigh in on our position and if it's a priority of ours to support it or not. After the B6 through B315, which cover 3 departments, DEVA, VDH, and DMH. Then there is a section for the house health care reimbursement rate recommendations. So that's where like Vermont Care Partners came in and requested a 3.5% increase. So that's where we reflect all of those requests. And after that is a section that includes other non-governor recommended requests. So that by the free and referral clinics, Regista Health and Benefit Assisters, Heart Association. And then on the back side are 3 more of those. And finally, the language needed section, which is just really for our tracking purposes.
Thank you.
Yeah, no.
For the record, no level joint fiscal, did most of this, not all of it, a lot of it should also be in your up and down, so if you need to cross-reference it or section. It's gonna happen.
Lori, please chime in at any point. Lori is my partner on this project, so please.
Yeah, and this is new for you too. I just want to say tomorrow, when we actually go through this again, we will be adding SASH as a line item. We have not done that yet. So we can talk about it today, but it will be added.
Okay, so we have traditionally done this by each person taking a moment to kind of reflect on what their 3 priorities are this year. We're going to do 5. So you list your top 5 priorities, and then we're going to go around the table and take turns with everyone letting us know, and we'll record your top 5 priorities. We want them in ranked order. And then in the end, we'll calculate that out and see which 3 or 5 items get the highest rankings. First, Lori, do you want to go through the line items and refresh everyone's memory together?
Yeah.
You want to do DEVA?
Sure. So is everyone clear kind of where we are? So we're the very top row, it says governors recommend one-time funding. B1100, B2, DEVA, the description is provider stabilization grants. Gross amount is 2 million and the state general fund amount is 2 million and it's one-time money. So this means that it's in the governor's recommend that we take $2 million one time and put it in the provider stabilization pot. This is something that was started during COVID, where we put into the budget money where providers who were having financial difficulties could apply through AHS to get stabilization money. And we have received a report, and through that process, we asked for a report. And so there was a report sent to all of us that showed kind of who has gotten the money and how much. And then they have to go through a process to show that they've stabilized. So that's all in a report. And so there is, I think 2.7 remaining in the fund. Don't quote me on that. And the governor is asking for 2 million more. Any questions?
Who's a provider?
I don't think there is specific language, but it is healthcare. Jen, can you help me?
Very much city council. I do not. Where this,
I know FQHCs have gotten it.
yeah, I mean, we've had different definitions based on.
I'm just wondering if nursing homes are considered providers,
What?
nursing homes, and in the emergency stabilization money, I think we gave $14 million.
So that's a separate.
That's separate. That's what I'm
That's
trying to understand.
So then that is the emergency financial relief. That is a totally separate fund specific to nursing homes.
Okay,
That's in jail.
Gail. So we can't comment on that?
Yeah, but.
You can, but it's
Out of their jurisdiction.
Right. I would go comment to human services.
Could we comment in our budget letter about it?
I would say that you should go talk to human services.
So it's 2 million, but there's no specific breakdown as to who it's going to, what.
So we have a report. It's in, you should have it. And of who the money has gone to previously. And AHS has a process that they set up, when someone applies. I think all, anyone under AHS, Dale or Diva, DMH is involved in the decision-making process of whether or not they get the money or not. And so I think our question is, do we still believe that is a worthwhile endeavor? And that it should be $2 million. Good? Yep. Okay. So then the next one, B306, Diva Personal Services. This is the Medicare assistance contract that we heard about that Diva is canceling as of July 1st, 2026. So it's a gross amount of $547,000 that would go away. State funds is $273,500 base money. And so this is the group within Vermont Legal Aid and the healthcare advocates that help people with Medicare, I think trying to recoup money. And I might need some help on that. And that the reason they're canceling it is what they've ever been able to recoup is less than it's costing for that team to do the work. However, it is a 5-year contract, I think, that was just restarted, but now they're going to cancel it. If I did not get that right, if anyone's in the room that wants to correct it. Any questions?
It's only legal aid.
It is specific for this contract. Yes. Yeah. All right. So the next line, B306, still Diva. This is the, I don't know what HAE stands for, but this is
Health.
Eligibility.
access.
Yeah.
Access eligibility.
Yeah.
So it's the 12 positions that Diva says they need for the redetermination and work requirement work that came through the federal HR1 bill. So this is 12 positions, gross, it's 994,000. In the general fund, it's almost 500,000. And that is, I think they testified that they feel their productivity will need, the workload will be 30% more than what they've been doing, and that these 12 positions are what they need to do that work.
So
And
maybe,
Nolan, obviously jump in anytime too.
maybe one thing we should point out too is the second column of numbers that's labeled at the top, staff, state/general fund. That's different than the gross on the left, right? So that the difference is federal funds. And we didn't list federal funds out separately, but really we highlight what's coming from the general fund because that's really how much we're spending.
What does the 9 months mean on that?
Meaning that so the $1 million, they are calculating for 9 months versus a full year
Okay.
because they won't hire them at the start of the full year.
Okay.
So they plan for 9 months of employment. And then, so what, if we approve this, then the next budget, we would have to approve the additional to get up to 12 months,
Okay.
That would be considered base, and it wouldn't show up in their budget unless they're changed.
unless they were changing. Yeah. Going way too easy. Okay. B307 DIVA. This is the Northeastern Family Institute NFIA rate increase. They actually haven't gotten a rate increase in quite some time, but do you remember what they do, Daisy? They're youth, right? Yeah. It's youth. I believe it's youth.
Inpatient, right?
I don't remember off the top of my head, but I see someone who does on the sidelines.
Hi. Johnson, Vermont Care Partners, so NFI is one of the specialized service agencies and they're supporting mental health for youth and families.
Good job, Lori.
I thought it was youth. Somewhere in my head, that's where that was.
They're not inpatient, but outpatient?
They have residential
That's what I
facilities
was
as well
remembering.
and do home and community-based work.
And when was the last time they had an increase?
So they do get increases, but this was at a specific part of their programming where they haven't gotten increases. It's been left out of their budget.
Okay. And it's under DIVA because it's Medicaid, but it's really for mental health. So that's 600,962 gross, 200, I'm gonna round up, 252,000 general fund. The next, are we good with that?
Yep.
The next row, which is the family planning rate change. So this committee put into the budget last year. Or the year before, I think it was last year. And this is something where, this is the coder in the room, Chair Black's the coder, but family planning could use certain codes to be able to get an increased rate and an increased match for family planning services. And so we had put this in last year. Now DIVA is saying they can't implement it, and there are conversations going back and forth between the parties. Personally, I feel it's like we're leaving money on the table for a very small amount, and other states do it and have been doing it for a very long time. However, DIVA is saying they can't do it, and so they took it out of the budget.
What would that do, Lori? I'm so sorry. So it's a coding issue here?
Right, so providers who provide family planning could use certain codes for family planning that would give them a higher reimbursement rate and draw down more federal funds.
Okay.
But DIVA is saying they cannot implement it.
So is that forever or can it be fixed? I mean,
So it is, they are saying they can implement it, so they are taking it out of the budget. It is our committee's decision whether or not we agree to take it out or we keep it in with language that says, come back to us and tell us what you're working on, how you're planning to do this.
We've already requested language from them, right?
BAA.
We requested language that would allow them to make it implementable. And I don't think we got it.
They did send a letter saying, trying to explain why they can't do it. And of course, it's always never simple,
Okay.
but essentially they were saying, I'll let them say it, but I do think that they're worried that they can't they're worried they can't guarantee that they can get 910 on all the codes the way that they're. And so the risk is that if we do this, it could cost us more than $85,000 if we don't get the 910. So that's the risk, that it could be as much as 300,000.
Yeah,
300,000.
Yeah.
If we say go do it, and then they can't get the 910, then they need another 200,000 to fully implement it.
But could we also say, go do it, but let us know if you're not gonna, like, before you get to that last.
Sometimes we do it that way.
But if other states can do it, why can't we?
They can do it, they might not be getting 910, or it might be the way that we are implementing our codes. I mean, it gets into the weeds that I can't even start to explain.
So there's still a possibility that we'll get more information from this through the budget process, but maybe not before we all decide tomorrow.
So when considering whether we're gonna make this a priority, Lori, do you want us to just have it as written here? That would be our vote.
I would think so, yeah, till we know more. The next line, I was not here for the testimony. So Daisy, I don't know if you want to talk about it.
ABA coding, this is the behavioral services that some of us were getting a lot of emails about because there were some coding corrections that DIVA made in order to be sure that the Medicaid program is following federal procedures for correct coding. And they are doing something to make sure providers implement practices in the way that they interpret the code to be written by the AMA. That will save us some money. So this represents that down from correct implementation of that code.
Okay, we good?
Yes.
The next one, DIVA Emergency Department per diem. DIVA is suggesting that we discontinue this. This was a per diem rate that we were giving to emergency departments for extended days of people seeking mental health treatment. We started this in July 2022 in response to the fact that we had a lot of people waiting in the emergency departments. We did not get the data for this, but DIVA has said that utilization has significantly declined, meaning we don't have as many people waiting in the emergency rooms anymore. We've, through this committee and with the administration, we've done a lot of work to help with the flow. And so they are suggesting that we discontinue this.
Didn't we ask for data to get some data on that
I don't remember.
reduced utilization?
Would you say?
I seem to remember that we requested data on the reduced utilization, like what is it now?
How many people are in the
How
corridor?
many people are waiting?
Yeah.
We can try and get that before tomorrow if you'd like. I do know just in talking with others, like stakeholders, that it is definitely a drop since the crisis began. Yeah. Dental incentive payment. So I think that, I'm sorry, yes, dental incentive payment. Again, they're asking us to discontinue this. This was something that was also implemented to help entice dentists to dentist practices to see more Medicaid patients. And if you remember, you may not remember, those who were here a couple of years ago, we also increased the rate reimbursement for dentists. It had been at like, don't quote me on these numbers, but like 50% or something, and we went up to about 70%. And that has been an incentive. And we saw some really good data, which I can pull that up if anyone wants it, in a previous year, that more dentists were seeing Medicaid, people who hold Medicaid insurance. And I know I've gotten a lot of emails this week, I think everyone has, from dentists that they feel it is still really important for them. And it's helped them because it's just Medicaid does not pay at the cost of what the care is for dentists. So that's what that is.
So the incentive was the increase,
Yes.
and that's still in place.
So the base increase that we did a couple of years ago, which I think took us up to like 70%, that's still in the base. This is another additional pot of money, which was an additional incentive.
So they would just like feed dentists with it? And how is that money spent if they're already getting the increase?
So
Right.
remember, we only went up to 70%. So they're still not covering the cost of care. And so they would, my understanding in talking with someone just before we came in here, they would provide to DIVA, who the data around who they're seeing and they would get, I don't know what, I mean,
Okay.
I don't know how much each one is getting. I remember the testimony from Diva was like, it's not a lot. And so they didn't think it was really an incentive. And they're saying it's an incentive.
Okay.
It's only 60,000 from the general fund, but 140.
Yeah.
And I'm sorry, is that separate? Like, I know QHC's delivered dental, is that separate from this?
Yes. I believe it is.
Independent,
Yeah, I think it's, yeah. All right, and the next one, increasing pharmaceutical drug copays to $4 for preferred and $8 for non-preferred for those who have Medicaid as their insurance. This was said during testimony that it was needed to comply with HR 1, which is not the case because we already Medicaid holders already have a copay for drugs. I think it's $1 for preferred, $3 for specialty. And when I was in a PROPS when this testimony was given, and the deputy director said, it's really because we haven't increased their copays in quite a while. And so they would like to, so basically Medicaid holders would be paying more when they go to the drugstore for a drug come July than they do today.
Lori, did you say it? Go ahead.
I was gonna also say, and a lot of times what happens is if folks don't have the money for a copay, the pharmacist can do it.
Right.
Or pharmacists also take an impact on the.
They cannot, yes, they cannot. Require a person to pay a copay without, in order to dispense.
Say that again? Sorry.
Jen Harvey lives in example, the pharmacist, if I recall, the pharmacist cannot refuse to dispense a medication to a Medicaid recipient, a beneficiary, if the person is unable or unwilling to pay the copay.
So this is a hit on pharmacists. Could be a hit on pharmacists.
And right now, did you say it's $1 and $3?
Yes.
And they want to raise it to 4 and 8.
Yes.
Pretty big.
We know what it is in other states.
No idea.
It just seem like weird numbers, go from 1 to 3 to 4 to 8, like.
And we could pick another number, or we could say, no, we don't agree with this.
I would add that for the whole time, I've been in this job a long time and the copays have been the same that whole time.
I know. I can see raising it, it just seems like a strange number.
I just want to understand the total revenue would be $1,100,000
Not revenue, it's
or
cost reduction.
cost reduction.
And by the way, you could, in your recommendation, you could say, well, we agree they need to go up and not like that, or you can say, so you can play with the numbers a little bit. Or you can say, leave them alone, but you're not tied to the 4 and 8, right?
Okay.
Does anyone remember if they tied this savings to any need that they have? I think that.
Need for cuts,
Yeah.
I think it's all tied to need.
It's all.
I mean, a specific program, like
No, I don't think so.
to fund the 12 positions.
I think they were trying to find reductions, and this was part of the platter.
Got it.
Ways they had to hit the numbers that they needed to reduce the budget by.
And if you remember in some of the testimony, their pharmaceutical costs are actually down already, $3 to $4 million.
It's also hard to know how much of that through the rebates versus other stuff.
Correct.
All right, anything else with that?
Do we want to know what other states do? Because here's the thing,
Sure. Pick a couple.
Florida, no copays. Florida.
Those are outliers. These are like Connecticut.
Okay, that's in Connecticut. Connecticut.
Do you think they're about to have to do copays?
Yeah, they're gonna have to do copays, yeah.
Okay, so that may change. Obviously, Connecticut, no copays. New Hampshire.
So why don't you just send that to us?
Okay,
That'd be great.
this is from the KFF.
What is that?
She's
Lori,
gonna send it to us.
Kaiser Family Foundation, they do a lot of research on stuff, so I'll send it, yeah.
But to Jen's point, with HR one, states will have to require copays. They already have copays of $1 and $3.
So you were saying with the testimony that we got, that what they were saying was not true, that it has to be a certain amount.
Right.
I think the confusion was, not everybody, when I've spoken to them, I've got different stories. There were some folks at HS who thought it was just a bee farm. And so they were like, we have to do it for everybody else. But I was like, I think we do co-pays for everybody else. So I think there was a bit of confusion in their testimony when they said they had to. That I don't think they were saying it because they were trying to be nefarious. I think those folks thought it was like a bee farm. So I think I'm trying to get clarification, but nonetheless, I'm under the impression right now that everybody is paying and not just the farm.
So we're meeting the requirements of HR one right now. We just need to decide whether we agree with a $4 and $8 increase
That's my understanding.
or not, or we want to modify that. Lori, do you want to keep
Yes, and it
going?
may also be helpful to understand what DVA has in mind, which I don't know the answer to, but for co-pays for other services that they may need to implement as a result of HR one. So there may be additional co-pays coming for this population that they are not currently
I
experiencing.
didn't think of that.
And finally, I think on this piece, I don't think the co-pay piece goes into effect another year. So even if we were
On
in
HR one.
HR one, so even if we were wrong and we didn't do it for everybody, I think there's still another year for them to fix or implement or have clarification. If we're not doing co-pays for everything, we should.
Okay, the next one is utilization management for DME is durable medical equipment, special rate agreements, code review, other limits. We didn't get much on this. I'll just read what it says in their book. The DIVA Clinical Unit has been engaged in several concurrent initiatives related to efficiency and systems alignment consistent with best clinical practice in the areas of DME, special rate agreements, coding reviews, and other limits. This estimate is based on a reduction of a 0.25% in the acuity adjustment applied in the consensus process for the intended outcome of these collective efforts.
Please translate.
No, I can't, but I will get more information on that before we talk tomorrow. Okay. We're going to VDH. You want me to keep going, Daisy, and then you can do DMH?
Yeah, we need to get going.
Okay, so VDH, Area Health Education Center, which is AHAC program support. This is the scholarships that we took a lot of testimony on in here.
Should VSAC.
VSAC is the next one.
Okay, so, yeah, okay, I see.
Yep, so one is AHAC,
Okay.
and that's the scholarships, and then the education loan repayment. Sorry, I should have put VSAC there.
And I got a couple letters of some students who have $400,000 loans. Obligation, which they're interested in family medicine. You're not going to go to family medicine with that kind of loan burden. So just to understand what it means sort of philosophically to choose family medicine, which is what we want for our state. So it's a deal.
Okay, the next one is the unused drug repository. This was a bill near, no, it's VSAC. I said it's,
Oh, sorry.
yeah, sorry.
I have a breakdown, by the way. Of how that breaks down.
Not right now.
No, yeah, not right now. So unused drug repository, this is a bill that was, I was gonna say is near and dear to Leslie.
Broken heart
We
here.
passed it a couple of years ago. VDH gave in testimony that they put out a request for proposal to do this work and didn't get any responses.
My
And-
research says that's not true. I'm just putting it out there. Just saying, if you choose not to fund to stand up a program, then just say, be honest.
So this was a program, correct me if I'm wrong, where it would take, like, I don't know, when my husband had cancer, we had all these drugs that he didn't use. And instead of like trying to figure out how to get rid of them appropriately, there would be a way to do it, and then potentially the drugs, depending, could be reused, or they would at least be disposed of properly. It was one of those feel-good bills. Everyone loved it. And unfortunately, they're saying that they can't do it, so they're just asking us to take it out of the budget.
So now we're breathing in the drugs that are being incinerated. That was one of the goals, was to improve our environment. I'm sad.
I think we all are. All right, and that is VDH. So there's no questions. I'm going to turn it back to Daisy.
B 314, forensic evaluations have increased. This is a general fund request for 645,000, and that cost covers evaluations that DMH has seen an increased number of for people who need competency assessments or competency or insanity assessments. Those are usually done by telehealth, right? By Innovatel, by a contractor. Amy's shaking her head no. Okay, I think a large portion of them are, but DMH can correct me if I'm wrong. But I just have a note in there. It seems like a pretty large increase. That's over $500,000, and it's going, I think, to contractors. I mean, we need what we need with that population, right? We want to be sure that those folks are taken care of and assessed by professionals, but I'd rather see, personally, money like that go to increase salaries of psychiatrists who live in Vermont. The next line is the Team 2, which we just heard from Commissioner Hawes about. Does anyone have questions about that or want to talk about it anymore?
Before we go to Team 2,
No,
I
I,
just want to have a question on a previous item. Sorry, I'm just not sure I know what it means when it says BAA item.
It was in the budget adjustment that we passed.
So now this is on top of what was in the BAA.
Go ahead.
I don't know, I'm assuming it's the annualized,
Yeah.
so show up in the BAA and then this is the annualized cost,
So we won't see it again in the BAA next time,
unless they make a change.
unless it's not right,
But
but,
if you don't do this, then you're undoing something you did BAA.
Right.
okay, that's what I'm confused. When it says BAA, I just need to. Thank you.
Wendy, what were you going to say about Team 2?
so, just because I didn't know very much about it until we got the testimony, was it Friday? I guess I just don't understand, like, there's already like this infrastructure in place in this Team 2. And I guess I understand that they don't like the criteria for it, or they want to improve the criteria, but I just don't understand why we're moving this in-house. I don't understand why we're moving this in-house.
I heard from the commissioner that she wants it to be more aligned, more closely aligned with the things that they're doing in-house.
I did get the part about like the the different services that could be more combined or more communicative with each
Right.
other. Well, what will happen to Team 2? Like this go away? Just
That's a
You
question for
asked-
Kristen Chandler.
okay. You asked for my question. That was my question. I just
Can I just add? So I think one of the things to keep in mind too with some of these, and I'm not saying this in favor or against, just in general. Over the years, so this is my 10th year in this committee, right? We have put a lot into place that has brought things into Department of Mental Health. For instance, we put into legislation and they hired a suicide prevention coordinator. And so with those changes and putting things like more money to 988 and trying to do more statewide things, I think they're finally looking at all of the programs that they contract out to say, well, we have these people now, we have this new statewide / regional process, we can take these things in-house. Again, not saying what favor or not favor, but that's what I heard from them.
And we're on Team 2, Alyssa. Okay. That's not the only training they're doing that with. Like they've also stopped doing with CHL, a lot of their suicide prevention stuff is out. Those are downs. And You Matter was one of the trainings that they've had for a long time. And that's why you remember when Kristen was in, I asked if she had ownership and trademark rights to that training, and she said no. So the fact that DMH has paid for the development of that training doesn't stop them from using her curriculum,
Yeah.
just like with You Matter and the other things. But that's fair. I mean, she doesn't have trademark on it, and they paid for the development of the content, and so it's up to them.
Okay.
So do we know the cost of bringing it in-house as opposed to the cost of contracting, benefits, all the personnel costs that go along with that?
They said that it was going to be absorbed by Jeremy and his staff.
Uh-huh,
So he has 3 people, and I believe Kristen said she had 3.
uh-huh. And the relationships we feel sort of can happen organically, I guess.
But it looks like it's a savings, right? So regarding the cost, it would be a savings to our general fund of 35,000.
So Jeremy's team is existing and they're not asking for any more appropriation to stand this up. Is that the?
Do we know that?
They did ask for an increase in their salary lines, but we're not looking at salaries and parts are not allowed.
That's part of the pay act. I mean, we don't have a whole lot of say over that.
So we just take their word that they can absorb it in-house.
So it's the team 2, staff now will not be affiliated with the new, they will.
They don't have they wouldn't have a relationship going forward. That's not stopping anybody from contracting with anyone. So if Kristen wants to contract with the fire halls, she can do that. EMH doesn't own the trademark. So that's up to them, but this is, I think, a way that the department sees of modernizing the crisis continuum, and that has been their focus for at least the last 5 years. Right, so with the whole 988 thing, mobile crisis, mental health urgent cares. And I think this is seen as a way to sort of bring in alignment, another piece of the crisis continuum, so that, any developments that are happening in those spaces are part of the messages and trainings going out to these people. Okay. Anything else about team 2? Want me to keep going?
Yeah.
Keep going. Care coordinator for children. This grant is one I would have to refer to my notes because I didn't type them in here and I don't remember what it was for. I think it was, Lori, do you remember, was this at the one agency?
I believe so, yeah.
Yeah, it's sort of a specialized role at one agency.
And I think they don't, person they were serving, they don't need to serve anymore.
Yeah. Yeah, they're rolling those services into DCF maybe? Okay, I'm not going to speculate anymore. Does anyone have questions? Would you like me to follow up with more information about that grant?
Hey, just so I think I know what it is. but
Okay.
This grant was, they would take care of one person, right?
Mhm.
And they don't need to take care of that person anymore.
Yeah.
That's okay. That's exactly right.
Let's talk about community outreach.
Ooh, came back just in time.
Community outreach is a program that we also talked about last year because it was proposed to be cut thin. It's a program where folks are out in the community to help people in crisis. It's a very low barrier end of our crisis response mobilization spectrum, and there's a proposal from the department that says we should cut this and instead direct folk to call 988 and someone will come out as part of the mobile crisis team. And what I've heard from many designated agencies and clinicians is that the mobile crisis team is a very different part of the response system in that they are required to complete more paperwork. It's much higher barrier. They can't just go up to someone and start assisting them in crisis. And they don't do the sort of, what's it called? They don't do like the roaming comb as the community outreach does. And then Lori, you have experience with this system.
Yeah, so community outreach is something that we started again in this committee a while ago. And it's in Chittenden County. Communities also pay in. So it's a state municipality process. And I'll just give you an example as a business owner, right? We had someone who was on our property, homeless person sleeping in a tent. And we just wanted to make sure that that person was aware of services that were available. And so we called community outreach and they were there probably within half an hour. And it was a conversation, right? Instead of it being some type of escalated thing. The other way I've heard that they're really used, several of the libraries where people who have needs hang out. Community outreach will come and talk and just check in on people. And it's a way that they're keeping the situation from getting worse and hopefully being able to provide services. Again, I question whether or not a 988 mobile response team would be willing and able to do the same thing. And I know we've heard from several of the towns, police and managers that this is really important to their communities.
Oh, yeah, it covers nine communities. I don't know if I said that.
I will say personally, I think I've had emails from other representatives of almost every single community because their communities have reached out to them. What a vital service is. I keep going back to sort of what you said is if you respond to everything as an emergency or as a crisis, it will become a crisis. And this is again, a very low barrier. This is who comes out when it's not a crisis, but there is someone in need that someone in the community has identified as, hey, can you help out?
Who oversees this project?
Howard
Center,
Howard Center.
which is a designated agency.
Right.
How much is, and it's 160 and that's all general fund?
Mm-hmm. I think the other thing that I would note is that this is the number that my law enforcement calls when they know that they're not the person who needs to help someone, but someone obviously needs a person to talk to. And I know my municipality has written letters in support of this project, and we only use about 14 to 15% of the calls come from Winooski. But that just speaks to how valuable it is to us, I think.
Can you explain in the notes, it says Epic and 211 integration? So that's not what I'm hearing you talk about. So I'm just want to make sure I'm
Is
understanding.
that in the wrong?
I think it's in
I
the
think it's
wrong.
one.
Yeah, okay. Where
Okay,
would it
ignore
go?
We can just ignore that.
Okay. I mean, would it go elsewhere? I
I
mean, I could make an arrow, but okay.
yes, it goes elsewhere.
I seem sort of concerned that, and this is the second year we've talked about this, there really doesn't seem to have been a lot of thought behind a transition plan. And how to transition. It's just sort of been this, oh, don't worry about it, mobile crisis can handle it now. And that doesn't seem like a very thoughtful design on how to go from one type of service to another type of service abruptly.
ESAC and APEC. Same.
Yeah. And it's currently in base.
Or was it in one time last year?
No, it's based.
The base.
Right, so could we do it one time and do a transition?
A transition.
That could work. I do feel like it can't just stop.
Disappear.
And here's my thing about this program, which is probably driving the department like up the wall right now. Because it keeps coming back and we keep pushing back, is I feel like with this focus on the crisis continuum and development of making sure everybody has, you know, someone to go to and someone to talk to and whatever. I feel like there's sort of an idea that there's the same approach and offerings and services in every community. And I don't think that is equity. I think that Chittenden County needs community outreach. I don't know that I could say that about every county. If we're making smart investments about fundamental services that people really, really need, like I absolutely feel like Chittenden County needs this, just based on the volume of people we have and the acuity of care they need. I feel like this is a really economical investment and it's a really humane thing to offer people.
And the proximity of all these towns
Right.
and cities.
Cities or villages, like we still choose.
You know, proximity to each other.
I respectfully disagree with you. I think there's a need in every town community. We have those same problems at home. Okay, but people like us up home see, well, that money went to Chittenden County, that money went to Chittenden County. And we have to depend on pretty much volunteers from our ambulance service and other people that are trained to do these. And our local sheriffs and state police respond to those. So
Is your
I don't want to say it's more so for numbers wise in Chittenden County, but it's just as important in the other towns.
I agree, those people need
Okay.
us too.
It's just a matter of degree.
Yeah, and I also think, you know, because Franklin County's designated agency would have mobile crisis, which serves a much smaller population. So, you know, do you think that maybe they would be better equipped to absorb this than Chittenden County's mobile crisis?
I don't know. I think they're two different things.
Yeah.
Well, they are, but I mean, the reason that this has been in Chittenden County is because there are these two really, really distinct needs that are so high at this level that it's almost like you need two different types of responses geared towards that, as opposed to some of the other lesser populated counties. Perhaps they can all be I don't know, you know, there are things we need all over the state. I mean, I think about Rutland has urgent children, urgent mental health.
Love that.
They have
My
they
favorite,
have a
most favorite
specialized program for just children in mental health. And you know what? Chittenden County doesn't have that. Franklin County doesn't have it.
So I will say, we haven't really been advocating for any of the other things on the list, so I would suggest we move on.
Next, CSIP, Collaborative Systems Integration Project. This provides community supports for justice-involved, non-Medicaid, non-SMI, old term for serious mental illness, population in Washington County Mental Health Service area only. So I think this is another case potentially of here's a service that's only benefiting one area. Why did they get it, not others? This program evolved from a single person, 24/7 program during Tropical Storm Irene to a program working with individuals involved in the criminal justice system who need support. I think one thing I would point out about this is, you know, the department is assuming that individuals served in this program are just going to shift to traditional outpatient services. But if they're non-Medicaid, assuming they're all private insurance, they would get tucked into the adult mental health bundle for DAs, which doesn't count toward their targets, so it's basically uncompensated care. So this is the thing I was pointing out to the commissioner, like if you're not, if this is going into their bundle and they're already hitting their targets, this is just an why can't I say that? It's articulable necklace.
Mandate.
Nexus, not necklace.
So that would be my concern about this, but I do appreciate that they are trying to, they're trying to streamline and be creative with where they can redirect people for services.
I got a rough question. Was all these funded when the pandemic money came, or these been funded for years?
These have been funded.
It's been funded.
Okay.
Before that, yeah.
Okay.
Okay, does anyone have questions about that one? No. Let's go on to Lifeline Suicide Prevention, CHL. CHL ran the suicide prevention portfolio with all of DMH's work. Included a lot of trainings and a symposium. DMH is proposing, since CHL has now closed its doors, that they shutter that program and sort of absorb the suicide prevention work within the department under Chris Allen. Remember, Lori mentioned earlier, we legislated that position a couple of years ago. So they now have a director of suicide prevention that they didn't have when this grant was initiated. I feel comfortable with this personally. I used the suicide prevention portfolio there, and I feel like Chris will be able to get it done.
Not to mention, it's hard to pay someone that doesn't exist anymore.
Well, they could contract with someone.
They could with somebody, but
I feel like the work will still get done. Safe Haven at Clara Martin. I'm gonna review my notes. I believe that's a residential.
Can you talk about what GC investment project means and the implications of that?
Yeah,
Want me to do that?
Nolan, why don't you talk about that?
It means that it's a global commitment, investment. So remember, we talked about investments and that it's, it's things that would not be Medicaid eligible in the absence of the waiver that fall under certain criteria. So they're just highlighting that this is an investment cost and not a straight Medicaid match. So for instance, if global commitment goes away, these projects will either be 100% state funded or they will.
But there's no real implication. It's just a bucket.
How we're paying for it.
And how we're paying out a global commitment.
And the investment funds are kind of a little.
I remember the whole list.
Because for a long time.
Yeah.
The DMH has put programs into the investment fund and they don't have as much oversight maybe, or monitoring and reporting requirements as the other global commitment things do. So things in there can be a little more loosey-goosey, I'm gonna say. And now it's a really good idea to clean up stuff that may be a little loosey-goosey in our Medicaid waiver.
But it's good that it highlights it separately in the budget because then we know, oh, it's coming out of this bucket and not out of the straight line.
Yeah.
So it's just gonna lower our global commitment investment costs.
Yeah.
Thank you.
And
you were talking about Safe Haven.
okay, safe.
Did we talk about Safe Haven? No, we got sidelined with GC investment.
We didn't talk about Safe Haven, and I might ask Lori to
Yeah.
help me with Safe Haven.
Yeah, this funding is for support services for uninsured adults to help with transitional housing and support needs. It includes case management, housing counseling, life skills counseling, and peer mentoring. Provides emergency shelter bed if one is available. If we allow this to go through, DMH will shift to traditional outpatient services for this population, which includes the services that I just listed that are medically necessary as part of a treatment plan. So it's a different way that they are proposing to help this population.
So that means that they're shifting it in-house, just to use their terminology. That's saying, is that fair? If. Like,
Not in-house to them, how Clara Martin as a DA would do it.
okay, so it would shift to Clara Martin,
But still, it's at Clara, Martin.
but the cost would shift to Clara Martin. If this went away, the cost would shift to Clara Martin.
Yes.
Yeah,
And Clara Martin, in what county are we in?
Orange.
Orange County?
yeah, I think so. Okay, youth in transition. Youth in transition services youth ages 16 to 22. And the department is proposing that these individuals can receive the services in a traditional outpatient setting, much the same as they did with the previous two items we looked at. 95% of them have Medicaid or private insurance coverage. So billing could be done there.
So can I add that, it sounds like we're shifting costs to the DA. We're shifting costs from global commitment to DAs by cutting these.
That's right.
In this particular case, they did say, as she said, that 95% of the people have Medicaid and we could be doing Medicaid billing for these, which we are not right now.
Because it's global commitment.
It's just the way the program set up.
But it doesn't change, none of this changes the case rate that the DAs get. The DAs still get the same case rate, but yet they have this additional person that's going to be coming to them for these services, right?
Yeah.
So they're just loading more people into the
Into the
DAs
DA.
without increasing their case rates.
And so could you define a case rate for those people who are?
Amy Johnson.
So Amy Johnson, Vermont Care Partners, there's an adult mental health bundle and a children's mental health bundle, and for every agency, there's a target. You hit your target, you pull down the funding, and those budgets are capped. So if your target is 100 for the year, and you hit 100, if you serve 101 people, you're not gonna get payment for that 101st person. So for agencies that are already hitting, this would be children's mental health bundle. So for agencies that are hitting their children's mental health bundle, serving these additional clients through that bundle, if you're already hitting that cap, you're not getting paid for those services for those clients.
Thank you.
Does DMH have a plan for that? Do we hear anywhere along the line?
I asked Emily when she was in.
Yeah, is that, and so that, I'm trying to,
No, they don't.
no plan. So once again, DAs are absorbing.
Yes. That's my understanding.
I would just say that's something I learned when we searched for a new superintendent, is that the greatest predictor of future behavior is past behavior. No further comment.
Okay, we're almost done and then we're gonna take a break. Elder care and reach up.
Yeah, that's what I was wondering.
So I'm leaving reach up to the committee down the hall to make a determination on.
Yeah, which we should talk about.
Yeah. Oh, okay.
I don't feel like we're able to.
And
are
about
we-
elder
and
care?
same-
Shift over.
Same thing.
Okay.
That's their
This is really. the-
Yeah, I was gonna-
cup of tea. So to speak.
Cup of tea. Okay, in that case, I think you want to take a break. Alyssa?
Yeah, I did. This seems like a good time to take a break. It's been an hour and a half of this, so let's take a 15-minute break. Let's be back here to. Yeah, we can find out the amount.
Because we're doing
240, and then we'll move on to the recommendations that we other non-governor recommended cuts that we've received.